Elisa Vasco or Maria de Graça Diaz, I don't know who will speak, about the TDS in Portugal, challenges and results. And yes, we have already your presentations, and please could you introduce yourself, because I have not your papers in my hand. Thank you.
I am Maria de Graça Dias from the National Institute of Health of Portugal. Okay. I am Maria de Graça Dias from the National Institute of Health of Portugal. As I said before, I work more in the food composition side. But now I am here to present the results of TDS in Portugal regarding the nutrients, and my colleague thereafter present from the exposure. So, first of all, I would like to thank the BFR, especially the scientific committee and the organization for the invitation to present the first total diet study developed in Portugal based on an harmonized approach. The harmonized methodology was developing during the TDS exposure project funded by the EU, and it was applied by the Food and Nutrition Department of the National Institute of Health, Dr. Ricardo Jorge. In brief, it enabled to establish the Portuguese exposure and intake assessments baselines, because it was the first one, for some contaminants and nutrients. All the analyses were done in our labs, so they are limited to our lab capacity. And it covered the adult and elderly population, so it not covered people below 18 years old. It consisted mainly of two phases, as the other ones: planning and field work according to the flow chart, starting standard operation procedures and templates of a quality management system. Planning phase was based on food consumption database, for which, after cleansing, resulted 1,070 foods, that is 40% of the initial foods. Thereafter, foods were mapped to FoodX2 classification system from EFSA. The average food consumption was calculated, and a list of core foods was established to be pooled into TDS samples, and at the end, the sampling plan was defined. The food consumption survey had a sample size of 3,525 individuals, which for our population represented 0.033%. The sample includes adults, the highest sample size, elderly and very elderly. It was a limitation. It is only 1 day, 24-hour recalls. This is the only available at that date. And the food is as consumed. As an important note, the intake of food supplements was not asked in this national survey, so this is significant for nutrients intake assessment. By FoodX2 group, the consumption coverage of TDS samples was in general higher than 95%, and from the initial 1,070 foods, more or less half, that is 528, were selected for the TDS food list. The most consumed foods belonged to composite dishes, water and water-based beverage, milk and dairy products, coffee, cacao, tea and infusions, and fruit products. These results evidenced that liquid foods, tap water was excluded, and composite dishes have the highest consumption in the Portuguese population diet. The fieldwork involved the collection of food items, the TDS subsamples preparation, pooling in TDS samples that were then homogenized, liquid, labeled, and frozen until the analytical step. At the end, the evaluation of exposure intake by the population was done. Although time-consuming, the food sample registration proved to be essential for the ulterior laboratory and data analysis, and the digital photo documentation was evaluated as a very helpful tool. Culinary treatment was relatively time-consuming because we have many of composite dishes for some food groups. Each TDS sample was composed by the same quantity of each subsample, usually 100 grams, with the exceptions of very heterogeneous, where we used 200 grams, and when they are very expensive products composed by very small pieces, you use only 50 grams. Our food collection in numbers. Our collection was done in 2 years. 2,724 subsamples were collected. Several ingredients to prepare some subsamples were also collected. At the end, we have 227 TDS food samples, 126 national, 17 regional non-seasonal, and 21 regional seasonal. The foods purchase costed 9,100 euros, excluding personal costs, 5,600 kilometers traveled. That represents a traveling cost of 1,750 euros. It covered 1.5% of our territory, and the population of the former Great Lisbon area, that is 5% of the Portuguese population. The analytical phase involves the laboratory analysis of inorganic contaminants and other elements, also of carotenoids, of mycotoxins, nitrates, vitamins, some vitamins, and all the main macronutrients and fatty acids. The dietary exposure intake assessment was performed based on a semi-probabilistic approach, combining the mean occurrence data obtained in the analytical step of each TDS sample with the recorded consumption of the corresponding food items by each individual participating in the food consumption survey. The linkage of occurrence and consumption data was accomplished through the FoodX2 food classification. The TDS samples were collected in some of them were in 4 seasons, and for this, the mean occurrence value was used for exposure estimation. The exposure calculation was carried out by Monte Carlo risk assessment software using the observed individual mean model. Management of left sensory data, that is, results reported below limit of detection or quantification, was done by substitution. For exposure and intake assessment, the upper bound and/or the lower bound approach were considered. The exposure results were expressed as mean, median, and percentile 95, representing average and high exposure population. The intake results were expressed as adequate percentiles to evaluate inadequate intake by the population. The exposure intake estimates expressed in milligrams per kilogram body weight per day were performed for the overall population as well for male and female separately, and by age groups, adults and elderly separately. For risk characterization, the estimated exposure values were compared with the health-based guidance value in case of exposure assessment and with the dietary reference value in case of intake assessment. Now I will present the results of the TDS methodology applied to intakes evaluation. The analytical determinations of vitamins A, E, D, B1, and B2, and lutein were done by HPLC method with the adequate systems of detection. And for minerals, potassium, iron, magnesium, phosphorus, calcium, and sodium, ICP-EOS or ICP-MES were used. All methods were accredited in our labs by ISO 17025. For all nutrients, EFSA values for dietary reference values were used. The AR, that is the average requirement covering the needs of half of the people in the population, and the PRI, population reference intakes, that meets the daily needs of most of the people in the population. If these values were not available in EFSA, the AI adequate intake was used. The NRV, nutrient reference value, according to the regulation 1169, are also present. For vitamin A was considered the preformed all-trans retinol and 13-cis retinol, and the provitamin A carotenoids using the respective conversion factors. 50% of the population study had an intake around 500 micrograms per day, with no difference between genders. That is more or less the average requirement. Regarding the maximum tolerable intake level, it was exceeded by only 0.1% of the population. The biggest contributor was the vegetable soup, 22%, and then with much smaller contributions, carrots, milk, flamengo cheese, and green bean soup. For vitamin E, alpha-tocopherol was considered. The adequate intake is between 11 and 13 milligrams per day, depending on gender. 50% of the population had an intake around 5 milligrams per day, so only 9% had an intake equal to or greater than the adequate. Regarding the maximum tolerable intake level, no one reached it. The food that most contributes to the intake was codabras. This is a composite dish, followed by eggs, vegetable soup, bread, olive oil, tomato, rice, and omelette. It should be noted in this graph that it is present in the vast majority of foods, all with small contributions. Vitamin D3 is naturally present in foods of animal origin. Mushrooms is the only food of plant origin containing vitamin D, the D2 form. In general, the synthesis in the skin through sun exposure to UVB rays is enough to meet the needs of this vitamin. If there is no synthesis, the most recent assessments made by EFSA pointed to 15 milligrams per day as the dose needed to cover the requirements of 97.5% of the population. In relation to our results, 50% of the population had an intake of 2 milligrams per day, and only 50% of the population had an intake of at least the nutrient reference value. Plice, sea bream, milk, octopus rice, omelette, breakfast cereals were the major contributors to the intake. Regarding lutein, it is a bioactive compound that scientific work has shown to be very important for the vision and brain in preventing dementia, which will probably be given vitamin status in the coming years. 50% of the population had an intake around 850 micrograms per day, and the intake considered effective of 10 milligrams per day was only achieved by 2% of the population. So, being a compound essential present in leafy vegetables, it means that the Portuguese population did not consume this type of food in large quantities. The biggest contributors were mixed vegetables, lettuce, vegetable soup, rapini, and Portuguese cabbage. For vitamin B1, 50% of the population had an intake around the average reference. The main contributors were pork chop, milk, bread, breakfast cereals, potatoes, and orange. The same situation was observed for vitamin B2. 50% of the population had an intake equal or higher than the average requirement. The highest contributors were milk, apple, bread, orange juice, breakfast cereals, and hamburger. Moving now to minerals, 50% of the population had a potassium intake around 2,500 milligrams per day. Approximately 75% of the population reached the nutrient reference value. The greatest contributions came from milk, potatoes, vegetable soup, bread, bananas, and coffee. Regarding iron, 50% of the population had an intake near the average requirement, and the biggest contributors were bread, breakfast cereals, apples, beef, and vegetable soup. For magnesium, 50% of the population had an intake around 200 milligrams per day. That is 2/3 of the adequate intake. The major contributors were bread, milk, potatoes, bananas, chicken, and vegetable soup. Regarding phosphorus, about 91% of the population reached the adequate intake, that is 550 milligrams per day. Main contributors were milk, bread, lasagna bolognese, cheese, Flamengo cheese, and chicken. For calcium, 50% of the population had an intake near 600 milligrams per day, a much lower value than the average requirement. The maximum level of tolerable intake by the population did not present health concern. The main contributors were milk, bread, yogurts, bean stew, vegetable soup, apples, and flamingo cheese. For sodium, this is not the ideal method to evaluate sodium, but it could be a good contribution. 72% of the population exceeds the safe and adequate intake recommended by EFSA. The male gender apparently ate more salt than the female gender. The biggest contributors, and therefore those on which campaigns could have the most impact in terms of reducing salt consumption, were bread, because it contributes with 12%. And we have some campaigns in Portugal now to lower this value in bread to 1 gram per 100 grams. Vegetable soup, chicken soup, rice, cooked ham, and chicken. As a summary, and based on this TDS study, inadequacy was more severe for vitamins E, D in case of people living indoors, and calcium. Inadequacy for vitamin A and iron were near 50%. For vitamins B1, B2, potassium, and magnesium, around 40%, and phosphorus was out of health concern. Inadequacy was evaluated based on average reference, and when this value was not available, it was based on 2/3 of the adequate intake. Comparing the TDS methodology with the results of our consumption survey, that is from 2016, the conclusions in terms of inadequacy, considering the percentile 50, are different for vitamin A, E, and B1. Some reasons are the consumption survey used in TDS is older. However, this one was not available. This more recently is not available when the TDS began. Consumer surveys were with different methodologies. In the TDS, 1 time 24 hours recall, and the last one is 2 times 24 hours. The consumption survey used in TDS included only foods, while the last one included food and supplements. The food consumption survey used food composition data, not an analysis of each sample. As a summary, regarding nutrients, around 50% of the study population presents adequate intake of vitamin E, B1, B2, and for the minerals potassium, iron, phosphorus, and magnesium. 72% of the population exceeds the safe and adequate intake for sodium, and vitamin E and D and calcium. Low intakes can be of health concern. So now, for exposure, my colleague will present the data. Evans?
So, good morning. So, moving to exposure, I'm going to present results on exposure assessment for contaminants, nitrate, mercury, cadmium, lead, and arsenic, and exposure and intake assessment for the elements zinc, manganese, copper, and selenium. Regarding nitrate, the determination of the occurrence in the TDS samples was carried out by ultraviolet detection high-performance liquid chromatography method, ISO accredited. And for the risk characterization, the admissible daily intake of 3.7 milligrams kilogram of body weight day was used. The estimated mean exposure for the overall population to nitrate was 1.2 milligrams per day, milligrams kilogram body weight day, and corresponds to 32% of the ADI. At the 95th percentile, exposure was approximately 3.3 milligrams kilogram body weight day. for each male and female and for each age group, and corresponds to 90% of the ADI. This ADI was exceeded by 3.2% individuals of the overall population. In all age groups and sex, lactose was the food that contributed the most to nitrate exposure, ranging from 80 to 31%, followed by vegetable soup. For mercury, a direct mercury analyzer was used to determine the occurrence values of that total mercury in TDS samples. And for risk characterization, we use tolerable weekly intakes for inorganic mercury and for methyl mercury. As we have analyzed the total mercury, according to EFSA, a conservative approach was done to estimate the occurrence of methyl mercury and inorganic mercury in these TDS samples. Therefore, we have considered for fish samples 100% of total mercury is methyl mercury and 20% is inorganic mercury. For seafood samples, we have considered 80% of the total mercury as methyl mercury and 50% inorganic mercury. And for samples other than fish and or seafood, we consider a logical zero for methyl mercury and 100% for inorganic mercury. So these are the results for methyl mercury. The mean estimated exposure to methyl mercury was 0.16 micrograms kilogram of body weight day, about 85% of the health-based guidance value used. At the 95th percentile, exposure was approximately 0.75 micrograms kilogram of body weight for each male and female age group, and represents 400 of the health-based guidance value for the overall population. So this health-based guidance value was exceeded by 26% of individuals of the overall population. The top 5 contributors for this exposure are codfish, eggs, swordfish, canned tuna in oil, and fish in general. For inorganic mercury, the mean estimated exposure of the overall population was 0.09 micrograms kilogram body weight day in the upper bound approach, and represents 15% of the tolerable intake. At the 95th percentile, exposure was approximately 0.23 micrograms kilogram of body weight day for the overall population in the upper bound approach, and represents 40% of the health-based guidance value. The codfish, the mixed fish stew, coffee, eggs, and herbal tea are the top 5 contributors for the exposure. Moving to cadmium, the occurrence determination of cadmium, as well as for the other contaminants and elements studied in the TDS samples, was carried out by an ECP-MS ISO accredited. For risk characterization of cadmium, a tolerable weekly intake was used. The estimated mean exposure for the overall population to cadmium was 0.90 micrograms kilogram of body weight in the upper bound approach, representing 54% of the tolerable intake. At 95th percentile, exposure was 0.38 micrograms kilogram of body weight for the overall population in the upper bound approach, and represent 155% of the age-based guidance value. This tolerable intake was exceeded by 5.4% of these individuals. And the top 5 contributors to the exposure are squid, boiled potatoes, bread, apple, and eggs. For arsenic, for the inorganic arsenic, the risk characterization used was a benchmark dose range. As we have analyzed total arsenic, according to HEF, so we have to make a number of assumptions to estimate the occurrence of inorganic arsenic in the TDS samples for the exposure assessment. Therefore, we have considered the value of 0.03 milligrams kilogram of inorganic arsenic in fish samples, a value of 0.1 milligrams per kilogram to seafood samples, and 70% of the occurrence value as inorganic arsenic to samples other than fish or seafood. So for the inorganic arsenic, the estimated mean exposure of the overall population was 0.28 micrograms kilogram a body weight day, and for the 95 percentile exposure was approximately 0.7 micrograms kilogram body weight day in the upper bound approach. Considering the benchmark dose of 0.3 micrograms kilogram of body weight, the risk is very low, with the exception of the highly exposed percentile 95 on the upper and lower bound, where the possibility of an effect cannot be excluded. For the benchmark dose of 8 micrograms kilogram, there was no appreciable risk of a clinical significant effect. The margin of exposure is greater than 10. Milk, rice, octopus rice, bread, and boiled potatoes are the top 5 contributors to the exposure. For zinc, the risk characterization used a tolerable intake level, and we have estimated the mean exposure for the overall population to zinc, a value of 7.3 milligrams a day in the upper and lower bound approach. At the 95 percentile, exposure was approximately 14.8 milligrams a day. 0.5% of the overall population exceed the upper level, and 33% of the male population and 43% of the female population achieves the PRI. The top 5 contributors to the exposure and to the intake are milk, cow meat, bread, cheese, and boiled potatoes. For manganese, risk characterization, a tolerable upper intake level were used. The estimated mean exposure intake for the overall population to manganese was 2.5 milligrams a day in the upper and lower bound approach, and that 95 percentile exposure was approximately 3.1 milligram days for the overall population. Only 0.22% of the overall population exceed the upper level, and only 28% of the overall population achieve the adequate intake. The top 5 contributors to the exposure and to the intake are bread, banana, rice, boiled potatoes, and vegetable soup. Concerning copper, a tolerable upper intake level was used for the risk characterization, and the estimated mean exposure and intake for the overall population to copper was 1 milligram a day in the upper bound approach. And at 95 percentile, exposure was approximately 1.9 milligrams a day for overall population in the upper bound approach. Only 0.21% of the overall population exceed the upper level. However, only 12 to 0.8% of the male population and 10.8% of the female population achieves the adequate intake. The contributors to this exposure and intake are bread, boiled potatoes, rice, apple, and vegetable soup. In the same way, for selenium, risk characterization, we have used a tolerable upper intake level, and the estimated mean exposure and intake to selenium was 116 micrograms a day, and the 95 percentile of exposure was approximately 252 micrograms a day for the overall population and for the upper and lower bound approaches. 2.5% of the population exceeds the upper level, and 73% achieves the adequate intake of 70 micrograms a day. To the exposure and to the intake, goldfish, chicken, sardines, canned tuna, in oil, and squids are the major contributors. For summary, for contaminants and for the exposure baseline, none of the contaminants studied show a health concern at the mean and the percentiles 50. Methyl mercury and cadmium present exposure values that exceed the health-based guidance value at the percentile 95. And for lead and inorganic arsenic, the margin of exposure indicates that the possibility of an effect cannot be excluded. For contaminants and nutrients, we have none of the elements studied show health concern at mean percentile 50 and percentile 95, and the tolerable upper intake level values were exceeded by small percentages of the population. Consider the elements as nutrients. Zinc and selenium seems to show less health concern than copper and manganese. Our final considerations. What are our achievements? Capacity to accomplish a TDS at national level using internationally harmonized methodology, and assessment of Portuguese population's baseline dietary exposure and risk of exceeding the health-based guidance values. We have started with a little success to promote the TDS as a public health tool and at country level, fostering the vision of a wider food diet survey system that would include periodic food consumption surveys and TDSs. Our major challenge, not having a TDS dedicated team. We are a few number of persons working on that. The delay in the analysis of the results for exposure intake assessment, risk characterization, and publication. Our future work is to finish the publication of the results obtained in this first TDS in Portugal. Further investigation, the difference between intake results obtained by the TDS and by the food consumption survey. Disseminate the TDS results among risk managers, policymakers, researchers, to inform new recommendations in research needs, prioritization of substances for further actions, focus on nutrients where an average requirement is higher than the percentile 50. Raise awareness for political decision makers on the importance of the TDS as a public health tool and the need of its inclusion in regular monitoring system, concerted action, WHO, EFSA, FAO, other international organizations, member states. And amplify cost effectiveness, articulate with the update of the food composition database for new analytic values. Finally, here are the publications done. We have a general publication in the first harmonized total diet study. We have a publication on nitrates, and under drafting are these some of these results that we have showed here. And thank you very much for your attention.
Yeah, thank you very much, Dr. Dias and Vasca.